So it's ECG cases, is this ischemia or not? So here's a 37-year-old woman with chest pain. What do you guys think? She's 37. There you go, hyperacute T1 V2. So this woman had a cardiologist look at this who said it's nothing. She got 2 negative troponins. She got sent home, and she died. This is something. These are De Winter's T waves. A little bit of ST depression, huge T wave, ST depression, huge T wave. It's a sign of LAD occlusion. You should never miss it. I myself was sent a case as an expert witness with one of these that died. In that case, the patient had 4 successive ECGs. They all looked the same. And they thought, oh, it's okay, we're just going to admit for a rule out. And the patient ruled in, big time. So that by the time they got the angiogram, the entire anterior wall was dead, and the patient was in the ICU for 4 months. And so there's a lawsuit there. 60-year-old woman with chest pain. Computer says, paced rhythm, no further analysis possible. There you go, inferior STEMI. So we are now, I've studied left bone branch block, and we now have the Smith-modified Scarbosa criteria for left bone branch block. We're in the middle of the perfect study, paced ECG requiring fast emergent coronary therapy. We have about 60 acute coronary occlusions where we have an ECG at the time of the symptoms, and we have a control group, and we have about, we analyzed a smaller group for an abstract and have about 70% sensitivity, 80% sensitivity and about 99% specificity of the Smith-modified Scarbosa criteria for paced rhythm. So I'm not going to go into those criteria here. This is sort of more a workshop, look at lots of ECGs, but it's all over my blog if you want the Smith-modified Scarbosa criteria. In a word, in this case, it's all got to do with proportionality. If you look for any concordant ST elevation, concordant meaning in the same direction as a QRS, I don't see it here, but excessively discordant, here there is way too much ST elevation for that amount of S wave. What's way too much? Greater than 25% is highly specific. Greater than 20% is very worrisome. Anything greater than 15% is kind of abnormal. But this is 100%. So this is diagnostic of an inferior MI. And in a recent online poll, 50% of physicians said you cannot diagnose myocardial infarction in the setting of paced rhythm. Well, now we know that you can diagnose myocardial infarction in the setting of paced rhythm, STEMI that is, not some non-STEMI, just as well as you can diagnose it in normal, with a normal QRS. How well is it in a normal QRS? This is something you should know, that 20% of acute coronary occlusions, complete occlusions, are missed on the ED ECG. That's people who have normal QRS. So they rule in for MI with troponins, and the next day they get their angiogram and their arteries occluded. And those people have worse outcomes, worse LV function, higher biomarkers, higher mortality. So I can talk for hours on this topic and show you hundreds of ECGs and rules and all kinds of things, and that's what I'm not doing this year at this conference, but one of them is paced rhythm. In this case, the cardiologist said you can't read STEMI, and this woman died. And in this online poll, 50% of physicians said you can't diagnose any MI in the setting of paced rhythm. And this woman died. Here's an elderly patient with chest pain, and this was sent to me by a medical student who does research with me. He knew more about EKGs when he was an undergraduate than most people do at any time. He had read every case on my blog until like 2013 when he went to med school. This is one of the cases he saw, and he diagnosed what here? This is left bone branch block. And what is there here that it should not be seen in left bundle branch block? There's a little bit of ST elevation in the same direction as the QRS. And if you don't believe it, then you wait a little while, and there's more ST elevation. Now it's inferior, lateral. The other one, it wasn't so obvious inferior before. A little concordant there, same direction as the QRS. Concordant in the left bundle branch block, the ST segment should always be the opposite direction of the QRS. Here it's the same direction, here it's the same direction, here it's the same direction. A little bit later, now it's much more obvious. He went to the cath lab and got reperfused, and now you can see not only in left bundle branch block do you see ST elevation that's diagnostic, you get the same T-wave inversion evolution that you do in other, in normal conduction. So first the ST segments resolve. You start to get a little T-wave inversion in lead 3 in AVF. A little bit later, start to get T-wave inversion there and there, here and here. What's that called? If this patient came in and had chest pain pre-hospital and was pain-free on arrival, you would call this inferior and lateral Wellens syndrome. Wellens described it only in the LAD distribution. So that was a case of Wellens syndrome in the inferior and lateral leads in left bundle branch block. This case was texted to me during a meeting, and I looked at it on my phone. 46-year-old male with chest pain. What did I say? What do you see? Well, there's a little bit of ST depression there in lead 3, and whenever you see that, you should think not that it's inferior ischemia. Ischemia is not localized to any wall. You should think that it's reciprocal to some ST elevation up here. Yeah, there's hardly any there. If I saw that by itself, I'd say, no, I don't know, that's just non-specific stuff. But coronary arteries go into distribution. You see, if this were a high lateral MI, and then I also saw posterior evidence of posterior MI, then I'd be really worried. And I'd go over to lead V2, and look, there's a little bit of ST depression. Well, most people, especially men, I think this was a man, most people, virtually all people have some ST elevation in leads V2 and V3. If it's only a half a millimeter or something, that or some. Almost nobody has ST depression in V2. So you put that together and you think, and there it is in V3 as well, that this must be a circumflex occlusion. So I texted back, activate the cath lab, and it was a posterior lateral MI with acute obtuse marginal occlusion, 85% thrombotic RCA, and it was not small. Peak CTNI of 58 nanograms per milliliter. Most of the time, the vast majority of these cases do not go to the cath lab acutely. The vast majority of these people get put on, they get a positive troponin, and their second or third troponin is positive. They get started on some anticoagulant, some extra dual antiplatelet therapy maybe, and then they get put on some ward, and then they get scheduled for the cath lab the next day. And by the next day, that thrombus, which was 85% now, may have occluded off again, and they've lost a lot more myocardium. Here's a 29-year-old black male who came in, it was his birthday, and he decided to take some ecstasy, and he came into triage and with chest pain, and he was like agitated, and he actually threw a chair in triage, and they calmed him down and said, okay, let's just get an EKG on you. So they got this EKG. And he's 29 years old, come on. What's he got here that, he's got a lot of ST elevation, doesn't he? Okay, but there are J waves there. He knows lots of upward concavity. He's 29 years old. He's a black male. I mean, it's just early repo, right? There's one thing about this that makes it, that cannot be early repo. And I'll show you too. This here, early repo always has an S wave in V2 and V3. There's 10% that do not have an S wave in V3, and they all have prominent J waves. It's called terminal, when it does not have an S wave or a J wave, as in this lead, it's called terminal QRS distortion. We studied this, published it in American Journal of Emergency Medicine. 170 consecutive proven cases of normal variant ST elevation in the precordial leads. Not a single one had terminal QRS distortion. Among anterior MI, it's at least 20% have that. So this guy was in terrible pain. His pain resolved, and they got the CKG and said, okay, he's just got early repole, send him into let's take him out of the critical care area, put him in the cubes, in the room, and get another EKG since his pain's gone away. So they get another EKG, and that's this one. Now this pain is gone. And the doctor looks at it and goes, oh my God, that means that first one was an MI. And as he's going to the patient, take him back and activate the cath lab, the patient goes into VFib arrest, and he could not be resuscitated. And this 29-year-old died.
I have a question. If I had that EKG that first one, I probably would have used your formula, because I like it and I use it a lot.
Except an exclusion to the formula is having terminal QRS distortion. Okay. That would have fallen out. It says that we did not look at anybody who had terminal QRS distortion. We called that an obvious LAD occlusion. You cannot use the formula for this case.
Well, there's like, when you go through the app, there's like...
Yeah, and that's one of the questions. Yeah.
I don't have to memorize.
Right, yeah. Rich? Yeah.
Still, what terminal QRS distortion is. I understand that there's not the normal morphology that you expect with early repole.
Okay, see this? When his artery is occluded.
How do I, I mean, that's a case. Do they all look just like that?
They look similar to this, yeah. When this does not go below the PQ junction, that S wave, that's terminal QRS distortion. Notice that when he reperfuses, his S wave is reconstituted. And this happens all the time. If he went to the cath lab and they opened it up, his S wave would reconstitute. The S wave is one of the things that often just disappears. Yeah, yeah. So I'll talk a little bit more about this. Here's this case blown up. There's no J wave there. There's no S wave. Here's a case. This is V2 and V3, nice normal S waves. All right, this is beautiful. Here's a case with an S wave in V2. There is no S wave in V3. It does not go below PQ junction, but it's one of the 10% of those that has a nice J wave, right? If it has that instead, that's okay. That's typical normal variant. Here's a case where there's an S wave in V2, great, perfect, but no S wave in V3. It does not go below PQ junction, and there's no J wave. This is another case of an LAD occlusion. I mean, it looks like a very benign ECG otherwise, doesn't it?
You don't think V2 is elevated a little bit?
Pardon?
You don't think the ST and V2?
Oh, all these cases have ST elevation, but normal variant ST elevation has ST elevation as well. And normal variant ST elevation may have as much or more as an acute MI. So that's the problem, is how do you differentiate the ST elevation that's normal from the ST elevation that's not normal? Well, this is one of the ways with terminal QRS distortion. And that's the case that we just showed you. So there's more to this. So I was reading through EKGs, just putting in interpretations, and I saw this one, and I thought, oh my God, if this patient came in with chest pain, then that is an LAD occlusion, and it was missed. So I go into the patient's chart. Sure enough, he came with chest pain. Sure enough, his initial troponin was less than 0.010, which is undetectable. Sure enough, he got admitted to a chest pain unit, and sure enough, his second troponin came back at quite elevated, 3.8, and by the time they get a repeat ECG, it's 5 hours after he gets the ED, and there it is. He's lost his whole anterior wall. So is this a STEMI or a non-STEMI? It is a non-STEMI, and he gets diagnosed with a non-STEMI, but his LAD is completely occluded when they finally take him to cath lab. His peak troponin is 140. His ejection fraction is 40%, where it used to be 65. So he's lost a third of his stroke because a non-STEMI, I give a whole lecture on the false STEMI, non-STEMI dichotomy. It is a false dichotomy. And this is one example of it. Here's a 46-year-old male who had chest pain. And, if you do the by the way, the formula I'm going to tell you about, I don't go into detail again, I don't have time in this talk. The formula would have diagnosed this just perfectly.
So the thing that made you get excited about that EKG, just to spell this out, is the giant T wave. Right?
The symmetric T wave. The symmetric T wave, and more than that, see that there's a little bit of ST elevation there, right?
Yeah.
Okay? Now, if it's normal variant ST elevation, there is always good R wave progression.
Right.
So this R wave should be bigger than this R wave. It's not. Right? And that R wave should be very big. That's why in the formula, it's the R wave and lead V4 is the one that counts. It should be really big if it's normal variant ST elevation. And in fact, the single most important variable in determining if something is normal variant ST elevation or ischemic ST elevation is the R wave amplitude. And that is true in all of V2 to V4, but the single best lead was V4. So that's the one that goes into the formula. We had an area under the curve of 0.85 using just the R wave and V4. So it's by itself, it's a very good discriminator. Okay, 46-year-old male, he has chest pain. Looks like early repo, right? Nice upward concavity everywhere. So when we do this formula, we can't apply it to people who have 5 millimeters of ST elevation. Well, he doesn't have that. Can't apply it to left motor branch block, doesn't have that. Can't apply it if there's ST depression anywhere, and he doesn't have ST, might say there's a little bit there. Can't apply it if there's ST depression inferiorly. Well, you might say there's a little bit there if you look closely, but we're going to say there's none. You can't apply it if there's T-wave inversion. You can't apply it if there's terminal QS distortion. And you can't apply it if there are Q waves in any of these leads, and there aren't. So we can apply the formula. So let's apply the formula. Well, the people who saw this patient did not apply the formula. They waited 20 minutes to get another EKG. By the way, there it is blown up. And I'm going to show you how the formula uses ST elevation at 60 milliseconds after the J point relative to the PQ junction. There's the PQ junction. There is the J point. It uses the computerized QTC, and it uses R wave amplitude and V4. The 4-variable formula adds QRS and V2. So how do we measure ST elevation at 60 milliseconds after the J point and lead V3? Well, you find that J point. It's right there. There it is. You go to 60 milliseconds later and go up to here. You measure from the PQ junction up to there. It's 3 millimeters. All right. So for this patient, his computerized QTC was 420. That tiny little R wave I showed you over in V4 was 2 millimeters. Comes up with a number 27.72. The most accurate cutoff was 23.4. Above that is LED occlusion. Below that is normal variant. Now, it's not perfect sensitivity and specificity. It's like 86% sensitive. Instead, they just got to repeat. This is it again. And then they get a repeat EKG 25 minutes later. Excuse me. Let's put them side by side. This is the first one, the second one. I actually see that this upward concavity has straightened out some. The T wave looks bigger here. The people who saw this patient and were appropriately getting serial EKGs to look for it, they did not see it. And in fact, even the ST elevation is a little higher there. So they admitted him for a rule out, and of course he ruled in, and he had an LED occlusion, and it was called a non-STEMI, and he lost half his heart. Maximum troponin I 130, proximal LED occlusion, called a non-STEMI. I have a post on my blog, 12 cases of the use of the formula, which is very instructive if you want to go there. Here are 2 cases of ST elevation in patients with chest pain. One is normal variant, one is acute MI. Which do you think is which? I'll give you a clue. The one with more ST elevation is not the one you need to worry about. So let's do the formula on them. This one's 23.76, which is greater than 23.4. And if you want to be really sensitive, use 22 as a cutoff. This one is 19.88, which is very low. Why is it so low? Because the QT is very short, and the R wave amplitude is very nice at 19 millimeters.
So that's not terminal QRS distortion because of the J wave?
Because this gets down to the PQ junction. Just barely. Yeah. 54-year-old male with sudden chest pain. This is, there are 2 pre-hospital EKGs which are identical to this. The paramedic who saw this patient saw this EKG and said, I'm going to apply Smith's formula. So he applied Smith's formula, and both of them, 3-variable and 4-variable, were very high. So he activated the cath lab pre-hospital, and he got to the ED, and this is and they recorded this ECG in the ED, and these are the numbers from this ECG. And the doctors there had never heard of it, and they were like, this is not a STEMI, deactivate the cath lab. And he said, too late, cath lab's coming in. And sure enough, this was an LAD occlusion. And I want to show you what he got such rapid reperfusion that his ECG completely normalized. This is what this patient's EKG looks like when his artery's open, and that's what it looks like when it's closed. There's a subtle difference. And the formula will tell you that difference. 45-year-old with chest pain. This guy has these huge T waves. It sure looks like it's an LAD occlusion. And I saw this guy, I thought, geez, this is bad. But then I did the formula, and it was very low at 22.02. And so I got another one, and that was it. And that was 19.63, which is really low. And I said, okay, well, maybe this is really his baseline. Let's get a formal echocardiogram. And we got a formal echocardiogram. He had no anterior wall motion abnormality using contrast. So if you have an acutely occluded epicardial coronary artery, that is one of the big ones, the main one, even branches, obtuse marginals or diagonals or whatever, and you have a high quality echo that has got to be done with DEFINITY contrast, bubble contrast, and it's got to be read by an expert. And if it doesn't show any wall motion abnormality, then you're pretty safe that what you see is not ischemia. But you got to get all that expertise together. Yes? Oh, we're done now. Okay. I'm going to end here then.